I want to try to have a back and forth with the people that have actually asked the questions and give the opportunity for people that haven't asked questions to just ask them off the cuff and have a more of a conversation about this. So first of all, is there anybody on this call that has like a pressing question that they didn't submit? If not, we can go to the first person on my screen that submitted a question is Woody, I think. So Woody, do you want just for the rest of the audience to summarize your question, and then I can get into it? It's pretty detailed and it touches a lot of good topics. So but go ahead and just summarize for everybody else what your issues are.
Thanks, Dr. Gandhi. Can you hear me?
Yeah.
Yeah. I guess with our question, I mean, we have lots, but we didn't want to get too specific to Maverick, I guess. But basically, Maverick has had a BT shunt at BC Children's Hospital. He's had a Glen at BC Children's Hospital. He's then had a VSD enlargement at the IWK in Halifax. He then had a Fontan, and it was an intracardiac Fontan, without getting into too much details. And then Maverick got really sick and got pneumonia while he was trying to recover from his Fontan, and it just really set him back. And we had to go to Toronto, and we made the difficult decision to reverse the Fontan. So he's had a Fontan reversal. And basically now our hope was always that they would retry the Fontan one day down the road. But now Sick Kids in Toronto is saying that the only option left is a heart transplant. So my question was just geared kind of more around big picture stuff without getting into the details. Would seeking out a second opinion or maybe asking somebody else for their opinion? I know it's difficult, it's hard. We have full faith in Sick Kids Hospital and the surgeon and his team there. But based on your experience, is it wrong for us to try, see if there is other options without just, going down the heart transplant journey today?
It's a really good question. To answer your last question first, it's never wrong to get a second opinion. Okay. But we have to take this a little bit more granular. Do you know the primary diagnosis of your son? Like what the
single ventricle, and he also had a left superior vena cava, so an extra one.
You don't know what kind of single ventricle though, eh? Like, does it say unbalanced AV canal or tricuspid atresia or double in a left ventricle or any of those?
Two VSD defects. I'll have to. I won't take a. I'll have to find the actual.
Yeah, no problem. So here's the deal. So the fact that they had to take down the Fontan at some point, and I presume it was within the first few weeks, if not sooner, after the Fontan, is a big red flag. So probably one of the hardest things for a surgeon to do is take down a Fontan. Not technically hard, but it's hard to admit that that's what's necessary, because everything that goes into the decision-making tree for a kid being a candidate for a Fontan is then thrown to the wind, right? You make all these assessments preoperatively, cath, echo, this, that, and the other thing. And you're like, okay, this kid's a good Fontan candidate most of the time. And we do the Fontan, and for whatever reason, it doesn't work. Now, I can tell you, in my long time doing this, that happened to me twice. The first time, I was a lot younger, and I had a hard time admitting that whatever decision we made was wrong. And I'll just tell you that the child died. The second time it happened to me, it was 10 years later, and I knew within hours that we made the wrong decision, and I took the Fontan down, and that was about 8 or 9 years ago, and that kid's still fine without any other surgery, at least without any other surgery as of a year and a half ago. So I think taking down a Fontan is a psychologically difficult thing to do, but when it's done and it reverses whatever badness is going on, it means it was the right decision. Now that leads to the next problem, or your question is to, well, what about the next time around? Should we do a Fontan again? And I will say, speaking as a surgeon, it's very difficult to see how you would embark on something that failed so miserably once, having the risk of it failing again. Now, there may be certain things that have changed over the course of time. Like, I don't know how long it's been between Fontan takedown and April 9th, 2024, but if it's been a few years, maybe stuff has changed, maybe anatomy has changed, maybe pulmonary arteries have grown, like, I don't know. And that can certainly change things, but maybe they haven't. And if there's other discernible reasons why a Fontan would be a bad idea, the heart function's not good, there's a valve that leaks a lot, this, that, or the other thing, that's another reason to push you away from repeating a Fontan. And the last thing you want to do is be saddled with a bad Fontan, because that's a real tragedy. Even if your son survives all that, the complications of a bad Fontan are no fun for anybody. So that's why I'm seeing into this, but that's why probably heart transplantation was brought out as an option. Now, heart transplantation's not free of charge. You have to get a heart. There's a lot of stuff that goes into it. There's lifelong immunosuppression and this, that, and the other thing. But like I said last time, you probably weren't there, but heart transplants shouldn't be seen as a failure. They're not. They're a different pathway to go down and not at all a bad one. The problem is getting a heart and obviously surviving the operation and all the things that go along with it. But in the wash, like if you were to analyze it over the years, kids that have had a heart transplant that do well do better than Fontan kids in the long term. Now, that you have to, again, you have to get a heart, survive the operation and all the rest of it. It doesn't mean that all kids do better, and that doesn't mean some kids won't have poor outcomes after a heart transplant, either in the immediate period or thereafter. But it's a complicated question to answer without actually knowing all the data. But also your initial gestalt is correct, that it's not about surgical trust or whatever. Getting another opinion's fine. You just have to be careful what you're asking and who you're asking. Because I'll just put it out there, if you go south of the border and ask this question, you're going to get a yes somewhere. Somebody will give you the answer you want south of the border, because it's a money-making business and they want your business. So just be careful about that. The Toronto guys, I don't know who the surgeon was. I mean, they're all very good surgeons. I respect all of them. There's some of them I don't know because they're new now from when I was in the game. But I know the institution well, and they wouldn't hire anybody that's not good. So like, I think they're respectful people. They also would not be opposed, at least they never were in the past, to you seeking a second opinion from somebody. I'm also happy to look over the detailed information. If you want to send it to me, I can just do that offline, just for the hell of it. Again, I can't tell you what to do because I'm no longer in it, but I can give you my gestalt.
That's fantastic. Thank you so much. And I think I'll reach out to you privately, Dr. Gandhi. His surgeon was Dr. Barron, so I'm sure you know the name.
Yeah, I know him. Yeah. Who did his first two operations at BC Children's?
Dr. Campbell.
Okay. Yeah, I'm happy to look at it, and you can use the email that I posted up there.
That's great. Thank you so much.
Okay, you're welcome. Okay, so let's see. The next person that comes up on my screen is Heather. Heather.
Hi.
How are you?
I'm good.
Your last name's Alexander, right?
Correct.
Do you want to ask your question so that everybody knows it?
Okay, so I am a adult with CHD. I had 2 open heart surgeries at the age of 5 and 6. They were, from what I remember, they were considered left ventricle myectomies. They were performed by Dr. Ashmore. So now I am 49. I've had a clean bill of health, for the most part, until about 2018. I got fitted with a pacemaker, and now recently I have AFib. So I have 2 children. I have a daughter who is 17, who is my exact carbon copy, and we both have Noonan syndrome, which is the SOS1 gene. Now, will my heart issues be a problem for her as she grows older?
Yeah, good question. And you had mentioned in your question that she was born with pulmonary stenosis but outgrew it.
Yeah, she outgrew it. Yeah. And I recently found out that I originally was diagnosed with pulmonary stenosis as well.
Yeah. So most heart defects, as you guys all know, are de novo defects, meaning they're not genetically inherited. You just had a kid with heart disease because it's not that uncommon. But
Okay.
some are. Noonan syndrome is associated with certain heart defects. The most common ones in Noonan syndrome are pulmonary stenosis, like you and your daughter had sounds like a mild variety of, which is a narrowing of the pulmonary valve.
Yeah.
That didn't require any intervention. A ventricular septal defect, which is a hole in between the two pumping chambers, which you guys don't have. Coarctation of the aorta, which is a narrowing of the aorta as it comes off the left ventricle and gives blood to the body, which you didn't have. And the last one is called a hypertrophic cardiomyopathy, which it sounds like you might have had a version of. So, because a myomectomy means that muscle is taken out of the heart where it's too thick. Typically, that's on the left side. And you might have had a milder version of it, but there are a variety of different hypertrophic cardiomyopathies, meaning a thickening of the heart muscle that leads to the heart not functioning well, that can occur in patients with Noonan syndrome. So I can't tell you if your daughter will develop a cardiomyopathy, but she's certainly at risk of developing one as time goes on because of her underlying Noonan syndrome.
Yeah, she is seeing a cardiologist as well. So.
The more time that goes on and the more clean bills of health she has, the better, obviously. I think her chances decrease as time goes on, but I wouldn't say they're zero. So if there are heart symptoms, shortness of breath, chest pain, exercise intolerance, that kind of stuff, you always have to think of a hypertrophic or a thick muscle cardiomyopathy in patients with Noonan syndrome.
Okay. Perfect.
All right.
Yeah, thank you.
You're welcome. The next person is Jessica. So Jessica, do you want to ask your question about Alice? You're muted. There you go.
Okay, I figured it out. Yeah, I have quite a few questions. She has a cath and an EP study coming up soon. She has the Fontan, I think probably in June or so, but her recent blood work was fairly abnormal. And so just kind of wondering if what that is an indication of, or if it means that we need to do the surgery sooner rather than later.
Can you remind me how old she is?
She just turned 4.
Okay. And so for everybody, Jessica's daughter has a form of single ventricle called unbalanced AV canal defect. So there's holes in between the two upper chambers, there's holes in between the two lower chambers, but the holes and the valves are oriented in such a way that one side of the heart's a lot smaller than the other side of the heart. So you can't just close the holes. So she's gone down the single ventricle route of a Glenn and then coming up a Fontan. So patients that have unbalanced AV septal defects, by virtue of that anatomy, means they have an abnormal set of valves in their heart. AV valves, that is, valves between the upper and the lower chambers of the heart. So instead of her having a valve on the left and a valve on the right, in between each upper and lower chamber, she has one valve. And that one valve is leaking. And so the real question is what to do with that valve if it's leaking. Now, first of all, it's important when you get these reports, and for full disclosure, Jessica shared the reports with me last night, so I've seen them. So when you get these reports, and I'm talking to every parent here, you have to be careful about the language that you read, especially when it comes to leaking valves. I used to joke with the cardiologist that the leakage of a valve was trivial to severe depending on the cardiologist that read the echo. So especially if it was them grading my work in the operating room. One cardiologist would call it mild, the next one would come in and say it was moderate, and the next one would come in and say, oh, it's the worst I've ever seen, go back on bypass and fix it again. So there's a lot of subjectivity involved in interpreting these things, especially when you go from mild to moderate, which is, I think, probably what happened. I didn't see the previous echo, but probably what happened with Alice's, because this one said mild to moderate, so I presume the last one said mild. So it's really difficult to know if mild, moderate is the same, different. Who knows? It depends on the cardiologist reading the echo. It depends on how cranky Alice was at the time of the echo. It depends on, so many things, the phase of the moon, all the rest of it. So the best way to assess those things is with a different kind of echo called the transesophageal echo, where they put the probe down her throat rather than on her chest. But kids need to be asleep to do that. So they would typically do that at the time of the cath because she's going to be asleep for the cath. So I presume they will do that at the time of the cath, do a transesophageal echo, which will better assess the degree of leakage. Now, having said that, then the question is, what do we do about the leakage, if anything? And really that depends on where it's coming from and how easy it is to fix. Because typically AV canal defect valves are harder to fix than just regular old valves. And you certainly don't want to make it worse. But there are some instances where, because of the orientation of the valves over the ventricles, you can actually become a lot more aggressive because you can make one of the sides a lot smaller and it doesn't really matter because you have the other side. So if it's the smaller side in general that's leaking a lot, then it's a lot safer to fix because it really doesn't matter how small you make it because you have the other side to bail you out. So it really depends on the degree of leakage and the assessment by the surgeon of, do I think this is something easy to fix? If it is, then definitely it should be fixed. If it's not, then it's better to just leave it alone. As far as the lab work goes, I perused it, and the only major abnormalities in the lab work, at least from the one I saw, was that the hemoglobin is really high, which is normal in a single ventricle kid. So your body compensates for your low oxygen saturation by making more blood, so to speak, or increasing your hemoglobin. So the bone marrow, which is the part of your body that generates blood or creates blood, becomes hyperactive. And that hyperactive bone marrow is what you want in a kid that has a single ventricle with low saturations. Excuse me, there does come a point, though, when it's overkill and the body does too much. And if your hemoglobin gets too high, and hers isn't too high, it's high, but isn't dangerously high. When it gets dangerously high, that means you need to do something about it. And the best way to do something about it is to increase the oxygen saturations, meaning do the Fontan. Really, really high is like 180s, 190s. I think hers was mid 160s or something like that. So the normal hemoglobin is 130 or 140. So it was high, but not horrible. So I'm not answering your valve question directly, but the indirect answers are she needs another test at the time of her cath, and then she needs assessment by the surgeon in terms of how easy is this valve. First of all, how bad is it? Because if it's just mild, I would definitely not do anything about it. But if it's more than mild and it's easy to fix, then fix it. If it's more than mild but not severe and hard to fix, then I'd leave it alone. Make sense? The last thing you want is for them to go in there, try to fix it, it get worse, and then she gets a valve replacement. That's what you don't.
Yeah. 2 years ago, when she had her collateral closed, her hemoglobin was at 214.
Yeah.
And
So
then they had to do a
she-
phlebotomy. Yeah. It was the whole ordeal.
Yeah.
This is
It's way better than 214. And so
Yeah.
that's, she was probably really cyanotic at that point.
Yeah.
And that's why her hemoglobin was so high. And now that her cyanosis is, what are her SATs these days?
Like 80.
Yeah, so they're good. So, and speaking of which, if she's 4 and they're 80, the other thing is there's no rush to do anything.
Okay.
You don't want to wait till a kid's old to do a Fontan. Like when I say old, I mean 7, 8, 9, that's old. But the difference between doing a Fontan at 3 versus 4 versus 5 versus 6, there's probably not a lot of difference. And if waiting gives people more information to make an assessment about things like valves or whatever, then waiting is not a bad option. So, surgery is about a couple of things. Really, it's about good operations and it's about timing and the right operation. Like that's it. If you have the right operation, the right time, and a good operation, you're not going to have a problem. But if any one of those is a bit off, that's when complications develop. So timing is the one that doesn't get enough credit. It's a lot of it's about timing. So I'm not saying she doesn't need a Fontan this summer, but make sure she does.
Yeah, right now we're trying to increase her heart function. We're adjusting dosage, and we just added Spiro. So hopefully that will help. Her function is not terrible. It's just like, it's mild.
Yeah. Well, she looks good.
Yeah, she's doing fine.
But you probably ate blueberries or something like that.
Fudgesicle.
No.
I hate it when cyanotic kids ate like blue popsicles or something. It drove me crazy. Anyway.
Yeah.
Okay, let's move on. So the next one I see up there, let's see. I don't think Jackie had a question. Catherine, Jada, and Paul. Do you guys have a question? Or you're here to listen? No question. Okay.
Listening for now. Thank you.
Okay, you're welcome. Sandy, is that Sandy from Victoria? Or from the island, rather? No question. Okay, the next one, let me see. Did not have a question. And one
I believe Lindsay had a question.
Oh, where's Lindsay? Okay, sorry, Lindsay, I missed you.
Okay.
Oh yeah. Okay, Lindsay, do you want to ask your question, Lindsay?
Yeah. Can you guys hear me?
Yep.
Okay. So my son has a mechanical valve in the mitral position. He's had it since he was 5 years old. He got strep pneumonia, and unfortunately he didn't get diagnosed in a timely manner. It took me 7 doctor's visits of crying for help for my son. And unfortunately, this was kind of during COVID. And instead of swabbing his throat, they swabbed his nose and they told me he was okay. And I was saying he wasn't okay. I knew something was really wrong with him. Eventually, we were sent to Children's Hospital. We were sent home, and it was a disaster. And anyways, a couple days later, we went back, and he was having immediate open heart surgery, and his mitral valve was completely destroyed. So he was septic, he had heart failure, and he was having strokes. One of his eyes was drooping. I had documented everything. I had photos of everything. And I wasn't heard as a parent. So I can't tell you how frustrating that was to not be heard about, that something was wrong with my son. And so now he has a mechanical mitral valve, and he's on daily blood thinners. And Sandy B, who's also on this call right now. Hi, Sandy. Her son also has a mitral valve. So we've connected. I'm also friends with Jessica. Hi, Jessica. So anyways, Dr. Gandhi, I saw you a lot during my hospital stay there. Me and Levi were at the hospital for a long time, probably a month. And then his valve clotted a month later. So we were back at the hospital in the ICU.
Oh, now this story is ringing a bell.
Yeah. So I've been following you for a while, Dr. Gandhi, because I do believe you're one of the only, well, not one of the only, but you listen to the parents, and that's like your whole purpose lately of kind of advocating for parents and for the healthcare system. I'm all about that. I feel like the healthcare system is collapsing and people aren't getting the care that they need in a timely manner. So I'm kind of on this push to kind of advocate for that as well. I just feel like there's a lot going on there. So yeah, my son's valve clotted a month after he had the open heart surgery to replace the valve. And then he had a major bleed as well. So we've been in and out of the hospital quite a bit. He's quite stable now, but he's got these future surgeries and he's on daily anticoagulants. And so, yeah, I'm just kind of curious. Like, I got thrown into the heart world. Actually met you, Dr. Gandhi, when he was like 2 days old, because he just came in for like a quick little ECG, just because I have Wolff-Parkinson White. So it's a very mild condition. I didn't even know I had it till I was about 30. But my son came, yeah, we met you briefly and you said, oh, what's your child here for? And I said, oh, he's having an ECG to see if he has Wolff-Parkinson White. And he didn't. He was born heart healthy. And you said, oh, good, like, good. I'm glad you're not needing to be seen by us. And that was our first interaction. And then I did see you in the hallways and whatnot. So thank you for I know there was a few times that you weren't part of his case, but you advocated for him because he was getting blood work done every day. And you said, let's stop poking this child every day. There's got to be a different way. So thank you for that. But my question basically is that if you know of any technology that might be coming in the future for valve replacements in the mitral position, I know that's a really tricky valve to work on. And if there's any kind of technologies that we could look forward to in the future so that it's not going to be such an invasive surgery. I just don't know a lot about it, but I'm learning quite quickly. And if you know any medication changes, because right now he's on warfarin, and if there's any kind of
Lindsay, can I ask you how old he is now?
He's 7 now, seven and a half.
His operation was 2022?
It was 2021. It was December of 2021.
Okay.
Yeah, great. He just turned 5.
I remember this story, and I think it was during some difficult times at Children's, which is probably why I didn't end up operating on him. But
we're going to operate on him, but we had Dr. Campbell, but he had infective endocarditis.
I remember the readmission, and I remember the story of a 5-year-old with the valve and the head bleed and all the rest of it. So, well, first of all, I'm glad he's doing okay, because if he's who I am remembering, it seemed pretty dicey there for a while.
It's really, really bad. Yeah. Every time.
Now, it's very unusual also for a valve to clot in a 5-year-old. Sandy can tell you that happened to her kid too, as I remember all too well. But her child was an infant. And so it's a lot more common for a mitral valve to clot in an infant than it is in a 5-year-old. But having said that, mechanical valves in children are just a pain in the ass. There's no two ways about it. That's why we try not to do them. We try to repair valves, but in endocarditis, sometimes that's not possible. Now, Jen, who's on the call, her son, I hope you don't mind me telling the story, Jen. Jen has a kid who had an aortic valve replacement, but in the aortic position, we have the option of doing what's called a Ross operation. So we take the pulmonary valve out, and we flip it over into the aortic side. And then in place of the pulmonary valve, we put in what's called a homograph, which is a donor valve from a human being. So that means that the aortic valve is the patient's own valve. And God was smart. He made the aortic and the pulmonary valve the same. So you can do that. It's a much bigger operation. There's a lot more potential risk and complication. Most of the time, it's fine. In Jen's son's situation, it wasn't, because he had a lot of pre-existing heart dysfunction, but the kid was a trooper and ultimately did well. But that gives you the benefit of having a valve that's going to grow with you and doesn't require any anticoagulation at all. The only downside is the pulmonary valve that's put in place of the pulmonary valve that's been taken out to use as the aortic valve will deteriorate with time. But oftentimes that's a long time. And nowadays, you can put in a new pulmonary valve through the groin in a lot of situations, and you don't need heart surgery for it. And even when you do, it's a lot easier to replace a pulmonary valve than just about any other valve in the heart. And lots of times you could do it without even stopping the heart. You have to go on the heart-lung machine, but you don't have to stop the heart. So it's a good option in a lot of circumstances for the aortic valve replacement. So why am I telling you about this? I'm telling you about this because there is another operation that most surgeons won't tell you about. It's called the Ross-2 operation. So the Ross operation is where you take the pulmonary valve out and use it in the aortic position. The Ross-2 operation is where you take the pulmonary valve out, you turn it upside down, and you put it in the mitral position. And so most of the time that's done in situations like your son's, where when they need another mitral valve, because he was 5, he's going to outgrow this mitral valve. And
Yes.
so when he needs a new mitral valve, that's the time to do a Ross-2 operation. It leaves you with a prosthetic, not a prosthetic, it leaves you with a homograph pulmonary valve, but a biologic mitral valve that came from him. So it's a very good option. But just like the original Ross operation, like at the time that I did Jen's kids' Ross operation, I was the only person in Vancouver doing the Ross operation. And I don't know if anybody that's currently working in Vancouver does the Ross-2 operation. There's a few surgeons in the States that I know do it. And I don't know if the guys in Toronto do it, but it's certainly something you should inquire about because that option gets you off Coumadin, which, I mean, Coumadin is just a major pain in the ass.
It is. I have 4 boys. We're super active. We all ski and snowboard. And there's Levi, who now can't participate in things that the family's doing. Like he's super, super active and super athletic. And it's kind of hindering his ability to be in sports and stuff like that.
I mean, he can. It's just he has to be super crazy careful about it because if he falls and whatever, you bleed. So I think you should ask about that. As far as new technology coming down the pike, there's a lot of stuff being investigated. I don't know how much of it's going to be applicable to your son at the time that he needs his new valve. Like there's these fibroblasts growing in culture that make valves. There's testing of animals being used to make valves. All of these things are being toyed with to try to prevent the need for blood thinners in valve replacements. The only good thing I'll say about the time that comes where he needs a new valve replacement is that he's going to be older, and by virtue of his age, he's going to be bigger. And so, I don't know what size mitral valve he had. Do you know?
I think it's an 18 or a 19, but Dr. Harris.
It has to be a 19 because they come in odd numbers. So if it was at 19, then hopefully next time around he gets a 25, and a 25 is an adult size valve. And so in theory, that valve should last a long time. It doesn't get you off Coumadin, but it allows you to live a lot longer with that valve. Now, there are other mechanical valves, and I don't want you to take this as gospel. There are other mechanical valves that are being produced that manufacturers say will have less need for systemic anticoagulation, so you can get away with aspirin. I don't want to tell you that that's going to be a possibility, and I certainly don't want you to believe the manufacturer. But again, it's going to be a few years, I hope. So it's something you need to look out for if the technology gets better, because the technology is way better now than it was 10 or 20 years ago. So I think at least there's hope out there that you can get by with less anticoagulation, or if you get one of these fancier options, no anticoagulation. But honestly, you're going to have to, like, I hate to tell you this, but you're going to have to keep doing what you did the first hospitalization, which is advocate for yourself and your son, because you're not going to get these options if you don't necessarily bring them up. Like the Ross operation in and of itself, I can tell you there's a lot of people that don't even get the Ross option because a lot of surgeons just don't want to do it because it's a hard operation. It carries more risk. It takes longer. It's a lot easier to throw a mechanical valve in and not worry about it. It's not the best thing for the child at all. But I can tell you, being a surgeon, what the mentality of some people is. So it's something you have to advocate for. There are now, I think, a couple of people in Vancouver that do the Ross operation, but I'm not sure about the Ross-2. So something you need to think about.
Okay, yeah, we would be willing to travel. Like I'm willing to try to pretty much do anything to get him the best care. So I'm advocating pretty hard for him. And Dr. Harris said that when we put in a new valve, it'll be an adult side valve. So like he's likely going to get an adult size valve at that point. And how long does an adult size valve typically last a child, like, or, you know, a teenager?
Okay, so if it's a St. Jude, which it probably will be, St. Jude tells you that an adult size valve will never, that the patient will never outlive the valve. Now that's not always true, but it's sometimes true. The answer is it should last a long, long time.
Like 20 years-ish kind of thing?
No, it should. Part of this has to do with the mitral valve too. Like if you had a mechanical aortic valve at the age of 20, you should never need another valve replacement, okay? If you have a big enough valve.
Yeah.
Mechanical mitral valve, I can't necessarily tell you that, St. Jude will, but here I also have to tell you this, that part of it depends, and I'm not meaning to throw anybody under the bus or throw any shade here, but I'm just telling you the truth. Part of it depends on how it was put in, because there's a lot of stuff underneath the mitral valve. Underneath the aortic valve, there's nothing there. Like it's just free space. Underneath the mitral valve, there's these things called cords and papillary muscles and all this crap in your way. And so if you don't orient the valve right, then the blood flow will be turbulent. And then you can get what's called fibrous ingrowth of the valve. And so the valve can get narrow from scar tissue that happens around the valve. So that's why surgeons are important.
I know.
So anyway, in theory though, it should last a long, if he gets a 25 or 27 valve, it should last a long, long time.
Okay. Thank you.
You're welcome.
And that mitral valve is probably the riskiest valve of the valves to replace, correct?
I don't know about that. I mean, I think it depends on the scenario, really. Like, mitral valve's a harder operation than an aortic valve, but it's not that hard. And again, like if I'm comparing not your kid, but a kid that just needs a mitral valve that's not in bad shape, to a kid like Jen's kid who was not in good shape. I mean, he was an outpatient, but his heart wasn't in good shape. Like those two operations, I would take an easy mitral valve over a kid with bad ventricular function and pulmonary hypertension like Jen's kid had any day of the week. So it really depends on the scenario. Like you're coming out of a scenario that was particularly bad because anytime a kid's in a hospital and needs an emergency anything, and especially emergency heart surgery, like
in the middle.
You're behind the 8 ball right from the get-go, right? Like we like to do heart surgery on kids like Jessica's kid who's eating blue popsicles and is an outpatient. And though may have issues, like is running around and you couldn't really tell the difference between her and a heart healthy kid. Kids on a ventilator in an ICU with endocarditis, like your hand is forced.
Yeah. Okay. So next time he has his valve replacement, he'll be likely very healthy at the time, hopefully, and it won't be so dangerous, possibly, you know, because I guess when they opened him up, his chest was just fully infected. He was septic. He was so sick by that point. Yeah.
And that's all a really bad situation, because anytime a patient's septic, they have all this stuff floating around in their bloodstream, which wreaks havoc on their body. And then on top of it, you add the heart-lung bypass machine, which wreaks havoc on a normal person. But the normal person can take it. Patient gets on a ventilator and has sepsis can't take that joke. And so that's why your son was so sick afterwards. Why he clotted his valve, I'm still a bit confused about that. But nonetheless,
again, that was another cry for help that didn't get heard when he clotted. I knew something was wrong, and days later I wasn't heard. And then we were in there and he was, you know, it was a huge clot and it was a huge problem. So I don't know what is going on, why the parents aren't being heard when we call the emergency cardiac line and say, look, my child is like spewing, vomiting water. Something's really wrong here. And if he was just there a month prior for this big open heart surgery, I think we should be seen pretty quickly in that case. And I was told to stay home and that it was probably fine. But I kept pushing.
Well, I can tell you why. And this is another good reason to loop Jen in, which I will in a second. But the reason why is I'm sorry if I sound like I'm getting on a soapbox here, but it's the lack of continuity in medicine these days.
Okay.
So, the ownership of patients from beginning to end is a value that unfortunately has evaporated a little bit over time. And so, when I started at BC Children's Hospital, the operator would call the person on the call schedule if some parent called and said, "We want to talk to the heart surgeon."
Mm-hmm.
And I found out about this, like, I don't know, the first time when some parents said, "I couldn't get a hold of you." And I'm like, "What do you mean you couldn't get a hold of me?" And I talked to the operator, and the operator said, "Well, you weren't on call, Dr. Gandhi." So I called somebody else. And I'm like, I don't really give a what the call schedule says. If it's a parent wants to talk to me, then the call schedule is irrelevant. Like, just put them through to me and I'll talk to them. Like, I don't care what time of day or night it is. But that is, I would say, an exception these days. And so you end up talking to people that don't know your story, or they're good people and they're knowledgeable, but they're taking call, right? And it's the keep them alive till 7:05 mentality, rather than continuity of care that, okay, Jen Searing called me. I know her kid's story, even though it was like 5 years ago. I still remember what I did to him in the ICU. I still remember the dialysis. I remember everything because it's imprinted on my brain. And even though I wasn't involved with your son, like, I remember parts of the story. So it's more helpful to have somebody that recognizes what you've been through. Sandy had the same problems when her kid's valve clotted, in terms of starting up I don't remember the specifics of all this because it was probably 7, 8, 9, 10 years ago, but there was a problem with starting the drug to bust the clot. And I think I was on my way out of the country, and I stopped off in the ICU and said some things that I probably shouldn't have said, but nonetheless, it got the ball rolling, and the clot busting medicine got started. But again, you have to, like, I'll do what it takes to get the kid taken care of and suffer the repercussions afterwards. But sometimes people don't want to suffer those repercussions. So it's a long-winded way of saying you just have to keep advocating for your kid. Now, so Jen's written this book about her journey through her son, and now has recently got something funded through the WCCHN. And Jen, I'm going to give you the floor. Why don't you tell everybody about it and tell everybody about your survey, and then you can post it.
Thanks, Dr. Gandhi.
First of all, it's always so wonderful to be on these chats and to connect with other parents. And I loved hearing from Heather too, as someone who's an adult. I always delight in hearing adults who have lived life with CHD. It's always really encouraging because I think as parents, we're always kind of holding on to that, like, what does this look like? What is longevity? Like, what's coming my way? So thank you for being on this call too, to kind of give us a face of someone who's had decades on this journey. So there's probably much that we can learn from you too within that. So my book is called When Your World Stops, and it's 30 short stories that all kind of stand alone to kind of help parents navigate. Like, when you're in hospital, you don't always know, like for you, Lindsay, you were thrown into it when your son was sick, and there's new language and new everything, and you don't always know where your resources were. So it was kind of a hope to try to bring our own experience. We all kind of want to bring something good from all the ick that we go through with our kids sometimes too. And for me, that was one of the ways that I processed. So my book is getting put into an audiobook through the WCCHN's funding, and that will be available to all families in Western Canada. Woody, it sounds like you might not be Western Canada, but I would let you find it too if you're from out east. And that would be a free resource that's coming your way within this next year. But in preparation for that, I also prepared a little short survey that I'm just going to dump into the chat now, of what kind of information would be the most helpful for parents to have. I'm doing a few short digital stories that will also be on the website that kind of puts a chapter or two of my book into a picture form. We all watch reels and TikToks and all sorts of things, and sometimes visuals are helpful. So just kind of getting a better idea of all sorts of families rather than just going off of my own experiences. We all have slightly different aspects of what we've learned and what we've found helpful. So it's very, very short. It's not a super long thing. If you guys are interested in giving some information towards that, that would be wonderful. I'd appreciate that.
All right, thank you, Jen. Yeah, I think it would be helpful. I've looked at the survey. It's very short. It will only take you a couple minutes to click off the boxes. And so
Okay.
I think it will be helpful for Jen. It will actually be helpful for me too. So, and feel free to share it. Okay, so I saw Sarah's name. Sarah, are you the Sarah that asked about heart murmurs?
Yes, I am the Sarah that asked about heart murmurs.
Can you expand on that so I can answer?
So I look after a child that's confined to a wheelchair. And when she was younger, she had a heart murmur. And we're just curious to know, do heart murmurs usually go away on their own, or?
Yeah, it's a good question. So heart murmur is one of those things that for most parents is like this black box of what the hell is it? A heart murmur is an abnormal sound that you can hear sometimes without a stethoscope, but most of the time with a stethoscope when listening to the heart. And it's caused by turbulent blood flow somewhere in the heart. So if all the blood's going like it should go, then there will be no murmurs, though you get the normal lub-dub sound when you hear a heart through a stethoscope. But when there's turbulent blood flow somewhere, then that creates an abnormal sound, and that sound is called a murmur. And every single kind of heart defect can cause murmurs. So to answer your question would require knowing what the murmur was caused by. There are certain murmurs that are called innocent murmurs or benign murmurs, and they're just caused by, for lack of a better way of saying it, a bit of weirdness and flow that kids usually do outgrow. And those murmurs can go away, but even if they don't, and they stay innocent murmurs, then there's nothing that needs to be done about them because there's not anything structurally abnormal with the heart. But I don't know how old this child is now, but if it's more than a year or two old and the murmur still exists and hasn't been classified as a benign or innocent murmur, then it needs to get evaluated by a cardiologist to figure out what the murmur is from. Because a lot of heart murmurs are not benign or innocent, and they're because there's an abnormal flow somewhere in the heart and something needs to be done about it.
Yeah, they had said something about it was part of the genetic disorder that she has.
You know what that is?
It's called SYN gap mutation.
Okay, that one's above my pay grade, so I don't know what that is.
Basically, it's where the cell has mutated.
Yeah. So how old is she now?
15.
15. Is she ever been seen by a cardiologist?
Yes, we've seen one before.
Okay. Well, I think next time you see your doc, just make sure the murmur's not there anymore. And if it is, then I think it's valuable to ask questions about whether it should get evaluated more, like with an echocardiogram.
Yeah. Okay.
And an echocardiogram will answer the question.
Okay. Awesome. Thank you.
All right. If there's anybody on the line whose questions I've forgotten, please let me know. Otherwise, if there's anybody that has any other questions, you can chime in anytime. But I think I've gotten the questions of the people on the line. There was a question about prostaglandin or phosphodiesterase inhibitors from Nick, but I don't see, or maybe it was Kim, but I don't see that person on.
Dr. Gandhi, I had one more quick question.
Yeah.
Hang on a sec, let me think. So Levi clotted within like a month of the open heart surgery. Is the risk for a clot more like significant in those first 6 months post-surgery? Like, is he kind of far enough out now where I don't need to worry as much about him clotting the valve 2 years post-op? Or is that always a pretty high risk? Like, I'm very—
No, it's not always a high risk. It's definitely riskier earlier on. It's definitely riskier the smaller the child is,
Okay.
but it's not a risk that goes away
Okay.
because of the need for anticoagulation. So anytime, you know, the INR drops too low or he gets sick and something goes off, or he starts, I don't know, he gets a spinach craving and eats spinach behind your back forever and a day. Like,
Yeah.
I mean, whatever happens can throw off that very intricate balance of blood clotting. And I don't know, what is he on, just Coumadin and aspirin now, or?
Yeah, he's on a half of an aspirin, so like 40-ish milligrams of aspirin because he had that bleed. So we kind of leaned back a little bit, and then he's on like 5.5 of warfarin a day. And I check his INR. They sometimes want to say, oh, you don't have to check it. You can check it once a month. I feel more comfortable really staying on top of that INR and checking it once a week, because I found if I went every 2 weeks and checked it, all of a sudden we're at a 1 point something and I'm giving him an oxyparin shot in his thigh. So I like to keep checking the INR. I don't see the harm in it. He's just a little finger poke. He doesn't even mind it. So I figure let's just keep on top of it so it doesn't have a chance to dip down super low.
Yeah.
Yeah. So I just.
So, I mean, to answer your question, I'm trying to answer your question thoughtfully, in the sense that, yes, it's riskier earlier on, but no, the risk never goes away.
Yeah, of course. Okay. Okay. Thank you.
There is a question, I missed it in the chat, about the pacemaker I placed in June 2021 for Jada is now under recall. Oh, Jesus. And we were wondering if you've heard about anything that needs to be replaced. She's a remote heart transplant. Do you know why it was recalled?
Hi.
Hey.
So you gave it to her as a graduation present, actually, the day after she graduated high school. And then we didn't go, when we went for our follow-up later on with Dr. Sanatani, it was good 6-8 months later that we were told there was actually a recall on this that came a month after you placed it in her.
So they never told
They
us.
never told us.
So what did Sanatani say you had to do about it?
He says they gave us a monitor that will be monitoring her once every month. Apparently, the glue that they used for the battery to that goes to the generator, that there can be a leak through there of bodily fluids, or even, I think he was saying condensation or anything, and could give her a shock. But because she's nonverbal, we don't know if that's going to happen, or if it is happening.
How old is she now?
21 and a half.
And when did I put the pacemaker in?
June 2021.
So it's been
It'll be 3 years this June.
Do you know how long it's got left?
The battery is still, I think, 8 years. She doesn't use it as much now that
she doesn't use it as much. If she's not pacemaker dependent and you have that transmitter thing, then she's probably fine to have it monitored, because it's not like if the pacemaker stops working, she's going to drop dead or anything like that, because she's not pacemaker dependent. So in that situation, I think you're totally safe. If a kid was pacemaker dependent, meaning if the pacemaker stopped working, the kid would stop working too, then I would say change the battery, because changing the battery is an outpatient procedure. It takes 30 minutes to do. You don't need to be hospitalized, all the rest of it. But in your situation, I think it's probably safe to closely monitor it.
Okay. Have you heard of that?
Yeah, there's been a lot of recalls over the years. It's always a very difficult thing to do, because it's not like your dishwasher or your car or whatever, like that you can just take it back in and get a new one. It really sucks when medical devices get recalled. It's because we almost never know what to do, because the threshold for recall too is very, very low. So as soon as they find like one kid's had a bad outcome out of 10,000, then they recall everything, right? Now, it might be justified, it might not be justified, but of course nobody wants to get sued, so they're going to do that to cover their ass. And that's just what they do. So it's a very difficult thing to do. I'm going to jump to Lisa, because I see Lisa and I liked her question. Lisa, do you want to share your question with the group, or I can read it? No problem for messing up the time. Do you want to share your question? I can. So Lisa's kid had a complex transposition and some other stuff, and also ended up, because of the other stuff, needing to get what's called a diaphragm plication, which means that one of the nerves to the diaphragm wasn't working, so that diaphragm stopped working. It wasn't because of the heart surgery, it was because of some other problem during the heart surgery. But anyway, the bottom line is he had 2 operations, the operation to fix the transposition and the diaphragm plication. And now the question is about hockey, a very Canadian question. He loves to play hockey, but we've always been nervous about him joining contact sports, given his medical history. So I'm going to preface the answer by saying I'm not a cardiologist, and if I say something that disagrees with your cardiologist, don't hold it against me and don't tell him it came from me. But my answer to the question is he should play hockey. He should get as good as he can get. If he goes really far and ends up making a lot of money, it's like a 20% cut that I get. That's the deal. But seriously, I we do these operations and we take care of these kids, not just to have them survive, but to give them good qualities of life and normal qualities of life. And from a contact sport perspective, there's no reason to worry. He's not going to hurt anything playing hockey because he's had heart surgery. The only reason not to do physical endurance sports is if there's still an existing problem with their heart, which doesn't sound like there is. If there was a problem that limited the amount of blood flow or the cardiac output or whatever, then that would be a reason to tail back a little bit on sports activities. But from a pure contact perspective, there's no reason at all to prevent him from playing hockey or whatever other sport he wants to do. As I'm sure you all know, Shaun White, who's the Olympic gold medalist snowboarder, was born with tetralogy of Fallot's, had a bunch of heart surgery. He's made that public. It's, you can have heart surgery and be an Olympian. And transposition of the great vessels is one of those operations where, though complicated, it restores the anatomy the way it was supposed to be. So all the blood flows where it's supposed to go. And as long as there's no residual problems, and I know there were some residual problems, but hopefully they're all sorted out now, there shouldn't be any impediment to hockey or anything else. Thank you all for coming. I appreciate your questions and your input, and please try to pass the word on. We're going to try to have this the second Tuesday of every month. Thanks. So it's a fixed time. And like I said, my email address is up there if you want to contact me offline. I'm happy to engage with you.